Hi everyone, my name is Lauren and I'm going to be sharing with you my capstone presentation today regarding barriers to health and social determinants affecting linkages to care. This is the overview and I'll give you a couple seconds to look it over. So it's known that health outcomes are also influenced by a variety of social factors outside of healthcare. Social determinants of health are the conditions in the environment where people are born, live, learn, work, and age. A pattern of health barriers has existed across age groups, racial and ethnic groups, and social classes. And as always, vulnerable populations are disproportionately affected by social determinants of health and associated barriers. While there are multiple domains under social determinants of health, I will only be focusing on 4 of them today. The first one is physical environments, where its associated barriers are from a lack of housing, transportation, and walkability. Trends that we see are that socially disadvantaged neighborhoods with a lack of safe environment and social structures has been linked to higher rates of injury, stress, and chronic illnesses such as diabetes and asthma. The second is healthcare systems, where barriers are from a lack of health coverage, provider and service availability, and linguistic and cultural competency. Trends that we see are that ethnic minorities have reported less participation in their medical decisions, more instances of them not having their resources translated into their native language, and their cultural values being looked down upon during an appointment. Another domain is education, where its associated barriers are with health literacy, higher education, and technology literacy. Trends that we see are that adults with lower levels of education are more likely to engage in risky behaviors such as drinking and smoking, and have less socioeconomic resources for a healthy lifestyle. The last domain covered today is economic stability, where its associated barriers are with employment, debt, and a lack of income. There's a trend of low-income individuals being less likely to be insured, less likely to receive preventative care, and have a higher risk of death. The goal of this study is to identify barriers within vulnerable populations that affect their linkages to care. It's also to track the amount of extra time required for an individual to receive health services when faced with a barrier, and to provide healthcare navigation and benefits counseling to individuals. I also want to take a moment to let you know that for the purposes of this study, linkages to care refers to the process of initiating services for persons to providers, community organizations, and public health agencies. This also includes promoting patient involvement in healthy behaviors and coordinating services. I worked with the California Hepatitis C Task Force, which is a nonprofit organization that supports advocacy, research, and collaboration regarding viral hepatitis and those affected by it. It should be noted that this study does not just focus on people with viral hepatitis, but on anyone aged 18 or older that had a problem with accessing health services. We started by creating flyers to distribute online and in public areas to promote a benefits counseling service where I'd help individuals create an individualized health plan to get their health services. I screen each individual, and if they were qualified, I'd follow up with them on a case-by-case basis until they received the health services they needed. Out of the 112 people who called, a total of 88 cases were completed, which meant they got the health services they needed. And a total of 16 people were incomplete, which meant that they did not call or email back, or they did not receive the health services they needed. I used the qualitative data analysis method of thematic analysis to go over my datasets, transcripts, and to identify common patterns for barriers and to create these case categories. This is the average time of case categories with and without barriers. All of the following showed an increase in time with a barrier, except for the combination of transportation when faced with an environmental barrier. As you'll see in the category of medication, for example, a language barrier created caused a 30-minute average increase in the time required for an individual to get medication-related services, whereas a technology barrier only caused an increase of 1.5 minutes on average, while a health literacy barrier caused an average increase of 10 minutes. For my entire data set, I wanted to highlight specific data a little more to show you that when there is a barrier, just how much more time it takes for an individual to get an appointment with a medical provider or support group. You'll notice that when a technology and language barrier is present, the time it takes to get an appointment more than doubles, and an additional 16 minutes is required when a cultural barrier is present. Similarly, the average time to get a COVID test or vaccine also increases when a barrier is present. These are the most common barriers faced by each ethnicity. The most common barrier for Asians was a language barrier. The most common for Hispanics was a technology barrier. For African Americans, it was an economic barrier. And for the white population, there was a tie between technology and health literacy. I also want to point out that about 60% of my calls were from the Asian and Pacific Islander population, which is why the numbers are so much larger in those groups. These are the most common barriers that occurred during these case categories. Language barriers were the most common and consisted of 32% of the barriers, while technology and health literacy barriers tied at second. This is significant because data shows that individuals facing health barriers almost always requires more time than individuals that do not face barriers, so perhaps the lack of time should be paid special attention to when creating policies. Second, barriers are not singular and often have relationships with each other. Individuals may often face multiple barriers at once. Lastly, healthcare barriers have a negative implication for the delivery of healthcare, patient health, and patient satisfaction. Some recommendations that I believe would help are that there should be more research that accounts for the subgroups within each ethnicity. Asian Americans, for example, can be broken down into smaller groups based on geographical origin, generation status, and primary language spoken. Some groups experience more barriers to health than others, which can skew the data, so it's important that we do not generalize these groups. There's mistrust in authority in some communities, so it would be effective to use a community-based participatory research intervention to engage with them. In addition, we could also use a cross-sector approach to create partnerships that can pool together resources. It can also get more points of view on a problem and improve community buy-in. More effort should also be put into developing screening tools for clinician and community health workers to uniformly collect data and identify barriers. That will make future reporting and analyzing data for policy creation more efficient. As seen in other studies, patients will actually delay care or forego care when met with a barrier, so we should create policies that increase accessibility to healthcare navigators for vulnerable populations. Next, we should redistribute resources to communities that lack clinics, healthcare professionals, and organizations that provide essential services. Increased incentives should be given to retain and recruit healthcare personnel, and additional funding should be given to support the size of specific communities. Lastly, we need updated reimbursement policies that recognize the role of social determinants and address barriers. This will hopefully promote the usage of navigators, social workers, translators, and other healthcare adjunctive staff to overcome some of the barriers to improve linkages to care. In conclusion, ethnic and racial minorities and other vulnerable populations are more likely to experience social determinants of health and their associated barriers. There needs to be some more acknowledgement that accessing health can take significantly longer when a barrier is present, and that time should be accounted for in future research and policy creation. Lastly, there should be more focus on policies screening tools, and partnerships when serving such populations, and the corresponding providers, persons, and organizations that takes care of them. Thank you so much for listening to my presentation today. Again, my name is Lauren, and you can get my number and email in the slide. Thank you.